I'm Rod Rourke, and I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, everyone, and welcome to the June 2017 edition of the PRS Journal Club podcast. My name is Jordan Frey, PRS Resident Ambassador from NYU, and as always, I'm joined by my co-resident ambassadors, Shuja Shafqat from Lehigh Valley and Chad Purnell from Northwestern. Today we have the honor of being joined by Dr. Deb Johnson from Sacramento and the current president of the American Society of Plastic Surgeons. And for our regular listeners, you'll remember Dr. Johnson did a podcast last year with our predecessors. So thank you very much, Dr. Johnson, for joining us and taking time from your busy schedule and being a guest again on the PRS Journal Club podcast.
Thanks, Jordan. It's really a pleasure. I enjoyed it last year and I was happy to get volunteered again.
So the article we'll be discussing next is Pursuing Mirror Image Reconstruction in Unilateral Microtia, Customizing Auricular Framework by Application of Three-Dimensional Imaging and Three-Dimensional Printing. This is by Drs. Chen et al. From Changgung Memorial Hospital in Taiwan. And remember, everyone, all of this month's articles can be read for free on prsjournal.com, and that includes an archive of all past Journal Club articles as well. To introduce this article, computer-assisted design, computer-assisted manufacturing, or CAD/CAM technology allows for construction of individualized constructs in surgical procedures. And this can be particularly useful in microtia ear reconstruction with a goal of producing symmetrical size, position, projection, and three-dimensional geometry of ears when you have a unilateral defect, comparing it to the normal side. And autologous microtia reconstruction with costal cartilage remains the most common method of reconstruction. However, it can be limited in its ability to construct a completely symmetrical ear given technical and patient-specific factors. Alloplastic techniques using often high-density porous polyethylene, HDPE or MedPor also called, have advantages given that there's no donor site morbidity and it can be perhaps more easily crafted. However, performed HDPE ears are uniform and may lack unique individual characteristics, while carving the construct can be difficult for inexperienced surgeons. So with that in mind, CAD/CAM technology is useful and can be used for contralateral ear anthropometric measurements from 3D scans to create a ready-to-use matching ear in patients with unilateral microtia. So the authors have been using this technique, and they reviewed 6 patients with unilateral microtia that had an average age of 7.6 years undergoing repair from 2015 to 2016 using HDPE. 3 of these patients had hemifacial microsomia, or variants of that, and three-dimensional imaging was taken of all patients. This was done at 45-degree angles for a full 360-degree imaging to capture the auricular contour and morphology. They uploaded this three-dimensional processing software where artifact and skin thickness was subtracted and individual modifications could be made. They then mirrored this to the microtic side and optimal orientation was set, and they created a base block as well to accommodate posterior contours. They then printed a final framework with biocompatible polyjet photopolymer material with a 3D printer. And then intraoperatively, they elevated skin flaps, removed vestigial cartilage, took the prefabricated model and used it to estimate skin redraping and plan areas for TPF fascia coverage. And then they used a MedPor block, which was carved using the prefabricated model as a guide. And this MedPor block was then placed, covered with the TPF flap and elevated skin flaps, and any remaining raw areas were skin grafted. They did use one drain as well. So in terms of results, they had an average follow-up of 10.3 months. They did note in terms of complications that there was transient alopecia in the ipsilateral scalp in 2 patients, and 1 patient had severe ipsilateral hemifacial microsomia, and in this patient they developed early implant exposure that was then salvaged with a free TPF flap. In terms of aesthetic results, they noted symmetric aesthetic results with regards to auricular shape, projection, and orientation in 5 patients who had uneventful healing. And they showed 2 case reports, one of a 7-year-old boy and one of an 11-year-old girl, both with concha-type microtia, and they were shown with excellent photographic results using the prefabricated implant as a guide for final MedPor implant sculpting. In their discussion, they note that three-dimensional imaging is a reliable, reproducible, and non-invasive imaging modality that can be used in craniofacial cases such as microtia. They note the prior work that's been done, printing 3D bioscaffolds or guides for cartilage molding, while also noting that in microtia, three-dimensional imaging allows for maintenance of shape fidelity of the external ear in development of patient-specific implants used to model the final implant. They also discussed, as this was in unilateral cases, that bilateral cases could theoretically be addressed using a composite average from a database of three-dimensionally scanned ears to create a quote-unquote population normal ear that could be used for bilateral defects. There are limitations. They noted that the artifact inherent in the three-dimensional scanning system is an issue, that there can be technical issues in hand carving the final implants, as the customizable MedPort implants were not approved in Taiwan, so they used the MedPort block. And there is a need for more study of biocompatible implant materials that can be used for auricular reconstruction to try to bypass kind of the middle step of printing this base and guide that then the final implant is sculpted out of. Overall, I think it's an interesting study. I think that CAD/CAM technology is being used in more and more applications in plastic surgery, so it's interesting to see how different surgeons are innovating their techniques with it. But it's obviously something that's evolving, and it'll be interesting to see where this goes. So, Dr. Johnson, I'm interested to hear what you think about this article.
I thought this was really interesting. Ear reconstruction is the fine art, and we've had some marvelous surgeons, Bert Brent, Dr. Nagata, who've done cartilage frameworks that are beautiful. And then Tad Wellish developed the MedPort implant, and then, John Reinisch has sort of taken it to a high art as well. To me, the idea of being able to utilize a scaffolding is very intriguing. I've done some MedPort ear reconstructions, and I felt like I got more definition to the framework because the temporoparietal fascia and the skin graft really mold nicely to it. There have been some beefs with it, with the possible exposure and higher risk of infection, and it's a little stiffer. But certainly in the hands of someone who's not a master carver, it's a much simpler way to do an ear reconstruction. And so I think it's more practical for the general plastic surgeon who is not a specific specialist in ear surgery. So I think it offers some intriguing possibilities. The MedPort constructs are really pretty darn good. So it seems like a large amount of work to be making individualized 3D constructs for every patient. And I wondered, with all of this fancy software, et cetera, they didn't mention what the cost of developing these constructs was compared to utilizing, an off-the-shelf implant. But I thought it was elegantly clever, and I love the fact that they were using all this high-techy stuff to make an ear. We've all dreamed of the day that we could use regenerative medicine to grow an ear in a Petri dish that we could then transplant onto the patient. So this is kind of the middle phase where we can construct a genetically matched construct and then cover it with the patient's native tissue to make a nice ear. So I enjoyed the article. I'm not sure quite how practical it is, but it certainly was a nice study.
I think those are all really great points, and especially it is important in the current climate to consider cost, and that's something they didn't go into, but would be interesting to see. Do you, in your practice, ever obtain 3D imaging for any cases, craniofacial or otherwise? Or where do you see, just in general, that technology going in the future?
When I was a resident, and this is back when dinosaurs roamed the earth, they were just starting to do 3D CT scanning. And when we talked about, boy, this would be great for facial fractures, because we'll be able to see all the fractures and maybe do facial implants. And it seemed like pie in the sky at the time, but now it's standard of care. So certainly doing 3D imaging when you have mostly a complex kind of craniofacial things, I think is invaluable. And creating custom kind of implants for Treacher Collins or hemifacial microsomia, where you have asymmetries, is very useful. I hadn't ever thought about it being used for ear reconstruction, but I can take that leap. I don't know that it's applicable to too many other areas, unless we get to the point where we can regenerate fingers or breasts or some such, that we might be able to develop some sort of mid-construct that would be utilizable. The thing about a study like this is it really jiggles your mind to think, how could we use this somewhere else? So it's very intriguing.
Shuja, what did you think of this paper?
I really enjoyed this paper for a couple of reasons. I really thought their use of 3D printing was pretty sophisticated and creative, I personally think that 3D printing and future techniques, whether it's bioprinting or tissue engineering, whatever, is a really interesting topic. Certainly, the results of the two cases that they showed in their pictures are really very good. And what I was most impressed with was how they accomplished so much in one stage as opposed to doing it in multiple stages, multiple donor sites for different flaps or different donor materials. The other thing I noticed is even though that their population was small and they really only looked at a few patients, the fact that only one patient had implant exposure, and Dr. Johnson mentioned the concerns over using MedPOR with exposure and infection, the fact that they only had one patient that had implant exposure was also pretty impressive. And I remember from our April Journal Club article on microtia, those authors did state that patients with more severe craniofacial anomalies or more severe hemifacial microsomia like that patient had tended to have less robust temporoparietal fascias. One thing that they didn't address, which is maybe a little nitpicky, and I tried to look this up, but pretty unsuccessfully, was if there were any specific issues with using, instead of traditional 3D printing, which is additive manufacturing, taking a SimPOR block and using subtractive manufacturing to get a shape that they wanted instead of making a model that they then use to manually carve the SimPOR. And it seemed to be more of an issue with the specific material, but I couldn't really find a lot of information on that. So that was just more of like a little nitpicky detail. But Dr. Johnson, you mentioned regenerative medicine, and you also mentioned how some of these technologies, when they first come out, really seem awesome, and then they kind of become standard of care, and certainly a lot fizzle out, but some stay on and become very standard in how we do things. And being president of ASPS, what is your feeling on how this technology will advance into 3D bioprinting, where we're using biologic materials to print with instead of synthetic materials? And how will that compare to traditional kind of tissue engineering or using biologic scaffolds that we then implant into patients? Do you have a feeling on where that's headed or what might play a bigger role in the future?
It's hard to predict because we don't yet know what we can do. But there's certainly a lot of research going on in trying to figure out how we can utilize regenerative medicine to use stem cells to grow organs or body parts, whether we can take a child's own stem cells and regenerate an ear. I think that those are kind of crazy ideas, but they're not seeming totally crazy nowadays because we know the pluripotentiality of stem cells, and we're learning what we need to do to tweak them to respond in the ways we want. So I think it's a matter of time that we will be able to regenerate new parts or missing parts in the future. And it has tremendous potential for many of the things that we do as plastic surgeons, congenital anomalies where patients are missing a part, or congenital diseases, where we could perhaps some of the horrible skin diseases like ichthyosis and the bullosa kind of diseases, where you could take someone's stem cells and perhaps grow them normal skin and cure their disease. There's lots of potential. It takes bright young minds like you three to come up with great ideas and get a grant from the Plastic Surgery Foundation and get that ball rolling.
Thank you very much. So Chad, I know you have a big interest in craniofacial, so I'd be interested to hear what you think of this article.
I thought this was a great article for a couple reasons. One, I've always found that microtia reconstruction is one of the most challenging areas of plastic surgery, and even experts sometimes get results that are poor. And I've thought that looking at the challenge of carving rib to reconstruct an ear, some of the experts' results are amazing and some of the average results aren't that great. And so whenever I looked at like what Dr. Reinisch was doing with MedPOR ears, it makes sense, but at the same time, a pre-made MedPOR ear isn't the same as reconstructing the exact contralateral ear like they are in these patients. So I think this paper was a really nice sort of natural progression of that, where yes, recreating an ear with an alloplast is a great idea, but it's not one size fits all. And I think they've really gone the next step, which is creating an actual custom ear with this alloplastic material. And their results really speak for themselves. They got great results. So I was really encouraged by this article. And I think, as they mention in the paper, the next logical step is doing this without the carving step and just having the 3D model create a 3D alloplast for them. So I think that's really going to be the next step, and we may be able to do that a little faster here in America because they're not approved to use that in Shandong. So overall, I thought it was a really exciting article. One of the things that I think comes up with all of this, Dr. Johnson, is that technology and innovation are really major components of plastic surgery these days. And now technology is really improving at a rapid pace. So we've got robotic surgery, we've got all of these new 3D printing technologies, we've got CAD CAM. And so as technology becomes more and more of a part of plastic surgery, how do you think we as plastic surgeons can keep up with all of these advanced techniques? And what do you think the best way is for us to learn these things?
You already feel like in your 3 years of plastic surgery training, there's already so much information you can't absorb it all. So now we're going to make you become a Silicon Valley engineer as well to practice your plastic surgery. I think as more innovation comes, it will become part of our armamentarium. Back when we started doing microsurgery, there were only a few people doing it. We thought, how are we going to teach everybody how to do microsurgery? Well, it just becomes part of the routine, part of your training. So I think these things will become part of our training. I think we'll be more intimately involved with the bioengineers. Perhaps some of you will be doing bioengineering fellowships after your plastic surgery training to gain a greater facility with that. But it'll happen. I always say plastic surgeons are the most creative and innovative doctors. So I think as we develop these techniques, they'll translate into good clinical practice and just become part of our reconstructive ladder.
Great. Thanks a lot.
I think that was a really interesting discussion of an interesting paper, and there were really a lot of good points that came out. But I think with that, we'll end our discussion of this article. Remember, everyone, to tune in to the other 2 articles that we'll be discussing on this month's podcast, as well as our previous and future podcasts broadcast every month. Also, don't forget to participate in our monthly #PRS Journal Club on Twitter, where we'll be able to interact directly with this month's selected articles authors. And once again, thank you very much, Dr. Johnson, for joining us.
Oh, thank you.